CancerX グローバルにようこそお越しくださいました。司会進行を務めさせていただきます、Kuge Kaorikoです。このイベントは英語で行いまして、同時通訳が入ります。ご了承ください。Speakers, would you put on your cameras, please? Thank you all for joining us here at CancerX Global. My name is Kaoriko Kuge from Fujisankei Communications International. I will be moderating this session. Now, I am here in New York. It's 8:45 p.m. on a Friday, and it's minus 11 degrees centigrade. It's very cold tonight. Now, today we have speakers from Washington, D.C., and much warmer Florida, and also from Japan. This is a 1-hour discussion, and we will be talking about closing the gap in the access to clinical trials for patients with cancer. You will join a panel of renowned experts in clinical care research for a discussion about why it is so important to close the gap in the access of clinical trials and how we should go about doing just that. I would now like to introduce to you our distinguished speakers. But first, one of our panelists, Dr. Naoto Ueno, will briefly talk about CancerX and its organization. Dr. Ueno is director of the University of Hawaii Cancer Center. He is CancerX co-founder, co-representative director, Japan Team Oncology Program founder. Dr. Ueno.
Great, thank you, Kaoriko. So good morning and good evening for all of you and all people from the globe. And so I'd like to spend a couple minutes just to talk about what CancerX is about. So X actually stands for crossing, and it has actually three meanings for this X. X to really collaborate by crossing different ideas, and X for really transforming and changing, and X for crossing out cancer. And that's what really established the CancerX in 2019. So the 2023 World Cancer Week, we have a theme, which is collective action. We want to really close the gap and really make a big action, making a difference to the world. And ultimately, we want to say what we call, if you were diagnosed with cancer, people could say, so what? So this is really what it means is to live to the fullest extent, regardless of where you live and how you were diagnosed with cancer. So CancerX is a proud member of the UICC. And UICC, as you know, to close the gap is one of the major themes for the past 2 years. And we hope that this will be aligning with the UICC goals that they have for another year. And I'd like to have a message from Dr. Carrie Adams, CEO of UICC. Okay.
Hello to my friends at CancerX, and thank you very much for giving me this opportunity to talk to you today. Congratulations on your World Cancer Week, and I know that you have lots of plans for World Cancer Day, being the 5th year that you've used this day to make an impact around the world and in Japan and in the region. As ever, the issue of inequity is causing so many problems in cancer control around the world. So the fact that you're focusing on equity again, I think is really important. And to address the inequities in cancer control, we need collective action. Collective action means working across sector with different organisations, different companies, and also individuals and government officials particularly to make a difference in cancer control. The theme of World Cancer Day this year is once again, close the care gap, which means that we as individuals and organisations have to do the right thing to ensure that everyone gets access to the information they need and the treatment and care they require in order to survive the cancer that they've been diagnosed with. Your session at the CancerX Global event will be brilliant. I'm sure it'll be fantastic, addressing the issue of inequity in clinical trials around the world. So thank you very much again for your continued support for World Cancer Day, the theme of inequity, and please close the care gap.
Hey, mahalo, Carrie. And so now I'd like to introduce our first panelist, which is my mentor, Dr. Richard Pazdur from FDA Oncology. And, I think it's a little bit hard for some people, like in Japan, what Dr. Pazdur does, but he is really the driving force of this accelerated approval of oncology, and his coming to FDA has transformed the speed of many of the drugs that we use now. So he's really the back force of making a difference in the world. So Dr. Pazdur.
Okay.
Well, thank you so much. It's really a pleasure to be here. And I'd just like to highlight several things that we do at the FDA. First, I'd like to talk about our efforts in promoting diversity in clinical trials and in drug development. We firmly believe that it is very important for our populations here in the United States to be reflected in the clinical trial participants in trials that are done. We believe that it's important for several reasons. First is really to promote trust in the medical system here, and this is especially important regarding the underserved and underrepresented populations in the clinical trial system. In addition to this, it will also provide experience in seeing how different patients respond to a therapy, both in terms to side effects of a therapy or to how well the tumor may disappear or shrink with certain therapies. So there's both a scientific rationale, also a social rationale, and one of social justice to ensure that all patients that are represented in the vast tapestry of the United States population is reflected in clinical trials. We realize that clinical trials are done on a global basis, and hence we really have fostered the concept of clinical trials being done internationally. So we have an opportunity to have participation of patients not only from the United States and Western Europe, Eastern Europe, Asia, but also we're very interested in furthering the development of entering countries from sub-Saharan Africa and Central and South America, which are currently underrepresented in multiple or in many oncology trials. So this will give us hopefully an opportunity to bring new sites into the clinical trials to develop oncology drugs. As far as an international regulatory system, we have monthly teleconferences, and the Japanese regulatory authorities participate in these, as well as agencies throughout Western Europe, South America, and Australia. These are aimed at really promoting regulatory harmony to ensure that all patients are represented in trials, and also to expedite the delivery of cancer drugs. And that's done primarily through the rapid approval of very effective agents to treat cancers. I hope this gives you a glimpse of what we do, and I'm looking forward to the discussion.
Professor Folakemi Odedina is also here with us. Professor and Enterprise Deputy Director for Community Outreach and Engagement, Mayo Clinic Comprehensive Cancer Center. Okay.
I have to unmute myself first. Okay,
Oh, yes.
Sorry that.
I think we missed the first part.
Yeah, so thank you so much for this invitation. I'm excited to be part of CancerX Global this year, and I hope this is going to be the beginning of great collaborations. And I really love the idea of the collective action, because it's really going to take a collective action for us to be able to close the gap and for us to be able to address disparities, especially when we're looking at clinical trials. So I'm really looking forward to the dialogue. So I just want to share a little bit of background. So first of all, the introduction was done. I am Professor of Oncology at the Mayo Clinic, and I'm also the Enterprise Deputy Director for Community Outreach and Engagement. I also proudly lead one of our initiatives at Mayo Clinic that focuses on clinical trials, and I happen to be the lead for the health equity aspect of that program. So I want to start by saying representation matters. And it does matter when we are trying to address health disparities, and it does matter when we are trying to address health equity. And when we look globally, and this is kind of, I'm glad to hear Dr. Pazdur really talk about this. When we look globally, there is lack of representation of minoritized and marginalized populations in oncology clinical trials. And this really is leading to an increase in cancer health disparities that we see within these populations. And so for us to be able to address disparities, we really have to embrace novel approaches by all stakeholders. This is what I think I want to bring. I want to talk a little bit about how the approach that we are taking at Mayo Clinic globally to be able to address disparities in clinical trials. So just a little bit, just to kind of give you a sense, you're going to see on the left-hand side, this is on clinicaltrials.gov, and these are cancer clinical trials that we have across the world, and you can clearly see, and I know that this is not all the data on clinical trials all over the world, but on your left, you can clearly see that there's disparities in cancer clinical trials that we have all over the world. You can see in some part of Asia, you can see in Africa, and this is one of the reasons why sometimes the therapies that are being used for cancer are failing, because we are really not enrolling these populations in clinical trials. When we take a look within the United States also, as already mentioned, there's disparities among subgroups as well. So there is countrywide disparities, there's also across the country disparities. This is another figure that really shows what we have in the United States at the top. But when you look at the World Health Organization 2020 source at the bottom on the left, you can also see disparities when you're looking at low income versus high income. So we kind of have to think about that. The disparities that we see in clinical trials is not only about race or ethnicity, it's also about your income level. It's also about social determinants of health. It's also about, the social economic status of people. And these are things that we really need to address to be able to have clinical trials. So, the assignment, I always look at the assignment that I'm given, and I always want to make sure that I'm fulfilling those assignments. One of the assignments that we were given is to talk about what are the inequity issues in clinical trials. This is something that I have studied for about 30 years in academia now. The issues that we have relative to inequity in clinical trials has to do with multiple factors. There's the personal factors that has to do with the cancer patients. It might be their beliefs about clinical trials. It might be they don't have trust in the healthcare system. It might be they have social economic issues or social determinants of health affecting them. Complicated with that is the provider level factors, because if we're thinking about cancer patients, that they really are exposed to providers. So the key thing is that, are they being provided the right opportunity where they are being treated to really introduce them to clinical trials? Sometimes we fail at the provider level and we are not providing that information and enrolling them as quickly as we can. Another problem that we have with inequity issues in clinical trials is protocol level factors. For example, inclusion and exclusion criteria. Sometimes we have this inclusion and exclusion criteria, or simply we have the issues that we are not translating the informed consent. So we have to ask ourselves, if people have different languages and the informed consent is not in your native language that you understand, that is another barrier. If we have inclusion and exclusion criteria that are so strict that is really excluding some group of people, that is another barrier. Then we have the health system level factors as well, the issue of access that might actually contribute to that. So how are we addressing this at Mayo Clinic? We are addressing this on a multiple level at Mayo Clinic, but I want to just focus on one area, but I can talk more about the other areas when we have the panel. One of the key things that we have now realized that we have to meet patients where they are. There are so many complex issues that are responsible for the lack of diversity in clinical trials that we have to figure out how do we meet patients where they are so that we overcome all the barriers that they have. So the use of technology, e-consent, e-diaries to be able to reach them. I think one of the things that COVID-19 taught us, we have to figure out a way to reach people when they cannot leave their house. And that is one lesson that we have to take from there. There are also processes that we have to think about that we can do. There are also enabling visits. One of the things that I'm proud of at Mayo Clinic, one of the things that we are doing is looking at clinical trials at home. Can we even take those trials to the home of the people so that don't have to think about the barriers of coming to those institutions, non-traditional ways of things. I'm going to pause and stop here. I look forward to more dialogue on this. Thank you very much.
Thank you, Professor Odedina. Okay, Dr. Kenichi Nakamura.
Yep.
He is the Director, Department of International Clinical Development, National Cancer Center Hospital of Japan. Dr. Nakamura.
Thank you. Thank you very much for the introduction. And I'm really great. It's a great honor for me to be here with such distinguished speakers. So I'm Kenichi Nakamura from National Cancer Center Hospital. And first of all, I would like to just briefly introduce myself. So I'm Kenichi Nakamura. I'm the director of the Department of International Clinical Development. But I've been engaged in the JCOG, which is the largest clinical trial group in Japan. And JCOG, most of the JCOG trial is domestic trials, but now we are expanding our clinical network to overseas countries, especially the Asia. And my interests include, platform trials for rare cancers or pediatric cancers. Those kind of diseases are not covered by pharmaceutical companies. And the second one is a decentralized clinical trials. So as Dr. Odedina mentioned, so the remote clinical trial is very important, even for Japanese patients. This DCT was, discussed in the previous session. So in this session, I would like to focus on the Asian clinical trial network. My kokorozashi, which is ambition in English, is to make the world better through clinical trials together. And my hobby is trail running like that and playing with Aibo, which is a robot dog developed by Sony. And what I'm doing right now is, expanding my clinical trial network to Asian countries. And previously, we have some collaboration with US, European countries, and developed countries in Asia, like Korea, Taiwan, Singapore, China. But now we are, trying to involve the more Asian countries, like Thailand, Malaysia, Philippines, Vietnam, and Indonesia. The reason why we are expanding our network is, I believe that we have some strengths in Asian networks. The population of Asian countries occupy 60% in the world. And the population is still growing, and the economic is developing, and the society is becoming an aging one. So that means there will be more cancer patients from now on, and there will be more needs for high-level cancer treatment. Most importantly, we have some area-specific cancers, like liver cancers, head and neck cancers, stomach cancer, or cervical cancers. But those kind of Asian cancers are sometimes neglected by the pharmaceutical companies. That's why we have to get together and, negotiate with the pharmaceutical companies and try to solicit more clinical trials in Asian countries. And this project is called the Atlas Project. And in this project, we are trying to build a robust clinical trial network. And we also offer some capacity building programs to Asian countries. And actually, we have some international clinical trials with Asian countries under this scheme. And we are trying to, introduce the genomic medicine in Asia in this scheme, and hopefully we can obtain and expand the drug indication simultaneously in Asia in collaboration with regulatory authorities. And to achieve this goal, we have developed a National Cancer Center Asian Partnerships Office at Bangkok. This is actually the first overseas office as a National Cancer Center. Our purpose of this office is to strengthen the local research support function for Asian clinical trials and with reducing CRO costs. Currently, CRO cost is very high to conduct Asian clinical trials. Then they realize low-cost Asian collaborative studies. So this office was established November 2021, and now we are trying to increase the number of staff in this office. This is an example of our collaborative study with Asian countries. So, the genomic medicine, we can, perform a genomic medicine under the National Health Insurance System in Japan, but it's not the case in other Asian countries. Then we collect the tissue samples and the blood sample from participating sites and make an NGS analysis, then make a feedback to participating sites. And the important thing is not only sending back the results, but also we have a teleconference with Asian sites. And such kind of, communications, direct communication with Asian investigator would be the key to success to make a robust clinical trial network. So that's what we are doing right now, and I'm looking for the further discussion today. Thank you.
Thank you, Dr. Nakamura. Okay, Dr. Ueno,
Great, thank you very
your
much.
thoughts, please.
So I'm going to wear a different hat, and I'm going to talk about Hawaii and U.S. affiliated Pacific Island. So I'm the director of the Cancer Center. And as you know, the Hawaii is one of the most popular vacation site for the United States and Asian countries. And our cancer center is probably one of the most beautiful cancer center, NCI designated cancer center that we have. Now, we have a mission to really impact Hawaii and the Pacific. And the question is, what are our catchment area? So I want you to understand that, that there's disparity issue in the mainland, but we have a different issue that we have. We're about 2,400 miles away from San Francisco, and our catchment area actually extends to another 4,000 miles to Guam. And between Honolulu and Guam, we cover this entire area. And these are what we call U.S. affiliated Pacific Islands. And we have Marshall Islands, Guam, Yap, Palau, Samoa, and it's almost, you can't even see the land, but Hawaii has about 1.4 million people and USAPI has about 0.6 million people. So we serve about 2 million people. So why is this a big issue? Because these areas has limited access to healthcare. And at the same time, they have high obesity, high smoking rate. And then nuclear bomb testing was done in this area. So we have unique disease that is happening in this area. So, and we also have a very diverse population. This diversity include Asian Americans and also Hawaiian and Pacific Islander, about 24%. And then there's another, basically a mixed race that exists. So there's no majorities. So why am I talking this so much? Because health disparities for Native Hawaiian is a big issue. Hawaii has the longest lifespan in the United States. Unfortunately, if you actually look at the lifespan, they're about 6 to 7 years behind. Native Hawaiian lives, their lifespan is about 7 years lower than the other population. So the Asian American, particularly like Japanese American, and is driving the longevity in the populations. So I like to say that we could conduct clinical trials, but as you could see that the catchment area, from one point from Honolulu to the other part, it takes about 7-hour flight. And then you could see this red dots, that's where we have our clinical trial sites. But you could see that most of this is what you see in the middle is Oahu, and our trial location is concentrated on basically on the east side of Oahu. But the moment you get outside of to the west side or north, access really goes down real fast. And on the right upper corner, you can see the different islands of Hawaii. Most of the island does not have any access. And the next place that could have access for clinical trial is Guam. So we spurred 2 million people with different like NCORP or Hawaii Cancer Consortium and the Cancer Center. However, the access is somewhat limited. So what's the cause? One of the thing is that Native Hawaiian Pacific Islander investment from the NIH is extremely low. It's one of the lowest than any other demographic, and it's only represent about 0.17%. And there hasn't been a lot of increase in the past decades. So challenges for conducting clinical trials is really the ocean. I wish this is more like mainland, you could just drive, but you can't drive. So our catchment is very, it's vast actually. We have limited resources in certain area, particularly outside of Hawaii. There's almost really no resources. Socioeconomics is an issue. We have a sensitive cultures and some people have a trust issue to the Western type of medicine. And we have a different diversity with a different cultural background. So many of the clinical trials that we could do outside of Hawaii is limited to cancer prevention. Reducing obesity or lifestyle modification is what we're trying to do. So challenges in the paradise. We need help and we want to be paradise in paradise for healthcare, particularly for cancer, but there's many ways to go. So looking forward for the discussion today.
Thank you very much. Now we would like to open the discussion, and doctors, please feel free to chime in at any time if you have any questions or comments. But first of all, just to open up the discussion and for people who are not in this medical area, Dr. Odedina, why is it just so important to be inclusive? Do patients with different ancestry respond to different drugs? Is this a biological thing? Do we actually know whether they react differently to different drugs? And also, you were talking about trust. I'm sure there's a lot of physical and resource problems, but psychological trust is probably very, very deep. How would you address that?
Okay. Was that to me?
Yes.
Yes. Okay. Great questions. So first of all, one of the things that we say is there is when we look at the components that we have as human beings, we have a lot of genetic differences in us, right? Apart from the fact that we have genetic differences, the environment where we live sometimes modulates the differences that we have. So this is one of the reasons why it's so important. Now, when we think about clinical trials, it is the gold standard for us to develop both therapeutic or non-therapeutic interventions that really is sort of tailored to some populations or tailored to you in order for you to be able to really be sure that that therapy is going to work for you or that intervention is going to work for you. So it's really very unique. The challenge that we have, right, is when you are not participating in clinical trials, right, when that drug is out and your population is not represented, you are still going to take that therapy as long as it's approved by FDA. And Dr. Pazdur can talk more about that. And then the question then becomes, if you don't have enough representation in you, then what happens? I do a lot of work in sub-Saharan Africa. One of the things that breaks my heart, in sub-Saharan Africa, especially for childhood cancer, is when I'm there, and a lot of the oncologists that are there, they are telling that majority of the children that they have are literally feeling that therapy is failing them. It's not the other way around. I always say it's failing them. And that's because it's not tested. And that is a key issue. So we have to make sure that we are represented, whether it's in Asia, whether it's in Africa, whether it's in, other countries outside the norm of North America and Europe, we have to ensure that we are represented. And I want to put this back on the farmer as well, because I think it's very key that if you are releasing a drug in a country, can you please just make sure that the populations of those countries it's been appropriately tested in them and it works well in them. There are so many issues and you know, that goes into the issue of trust. In the United States, and especially for the minoritized and the marginalized communities that we see in the United States, is historical. So for example, for African American, it's the eugenics, it's the Tuskegee, it's the issues of the healthcare system, it's the issue of how people even are treated right now because of your social economic status, because of the way you look, because of how different you are, or you belong to the LGBTQ community. All those things contribute to the issue of psychological trust that makes it very difficult. And I think the onus is in all of us to really figure out how do we begin to address this problem. This is really a huge challenge that is not only in one country, it cuts across other countries, and it's really very important that we address this problem. Thanks.
Dr. Pazdur?
Well, I think, you know, go ahead, I'm sorry.
Oh, no, please, go ahead.
Well, one of the things that we have seen during the COVID pandemic is medical distrust in the United States. As you could see, if people follow what goes on here, there's been tremendous debates about whether patients should receive vaccines, different therapeutics. So this has become highlighted in the United States, this whole issue of trust in the medical system. And I think one way to build trust, and we've had during the pandemic numerous patient-focused discussions, is really the need for patients to have representation in clinical trials. Repeatedly, we've heard from patients that they want to see patients like them entered in clinical trials. And I think that's one of the most important things that we can try to do, is to try to have not only in the late clinical trials that lead to clinical registration of drugs, but even when drugs begin phase 1 testing and very early testing, is really to make sure that we have representative populations, because this can give us early signals into perhaps different effects that a drug may have in a patient population. But you know, one of the things that I think is very important to discuss is ways of addressing inequity and really encouraging patients to enter into clinical trials. When I began my career in medical oncology, and that was almost 40 years ago, about 5% of the US population entered clinical trials. It's not that much different, okay, in a 40-year period of time. It has not increased that much. And what we really have to do is have novel ways, including decentralization of trials, bringing the clinical trials to the patient rather than having the patients come to the clinical trial. And I think that is one thing that will be paramount in really encouraging the underrepresented, the marginalized populations in participating in clinical trials. The other thing is to make clinical trials more easily understood. Even our informed consents at this time are highly technical. There are multiple patients, and many times patients, I'm sure, don't even read these informed consents and basically ask their doctors, "Doctor, would you give this to your mother? If you would, if you're asking me to give this to receive this." So here again, it's really the physician and the patient that has to have this trust. And a lot of times that's going to be accomplished by really bringing the clinical trials to the patient.
I understand that United States has the most clinical trials in the world. And I understand the standards are very high. And there's a guidance from the FDA issued about the diversity plans that you have to give metrics of the diversity, and you're very strict about that. So it's a very high standard. Now, as the United States FDA, what do you think about globalization and offshoring clinical trials? Because these pharmaceuticals companies, a lot of them are from America. What do you think about that?
Well, we believe that clinical trials are a global enterprise, okay? Pharmaceutical companies have to register drugs throughout the world, including Japan, including the European countries, South America. So we totally support and we realize the need and the strength of doing what is called multi-regional trials, where patients are entered in the United States, Canada, Western Europe, Africa, the whole global society, so to speak. And that gives us a tremendous opportunity if a large number of patients are entered from various countries and various regions to examine if there are any racial and ethnic differences between countries and between peoples. And these differences could be called what is known as extrinsic differences or intrinsic differences. The extrinsic differences are primarily the medical practice issues, dietary issues, how medicine is practiced. The intrinsic involves how an individual, the genomics of a patient or the genetic makeup of a patient that may affect how they handle a drug or a particular predisposition, genetic predisposition to a disease. So that has to be examined, and here again, we're very interested in promoting multi-regional trials because we believe that this is the best way of developing drugs on an international basis.
I don't want to sound like mean, but from a very non-medical perspective, I feel like if America is doing something that they could do in their own country, are they just exporting whatever they cannot do in their own country and doing it outside of their country? That should not happen, right?
We certainly could not develop all of the cancer drugs. And here again, I think it's important to realize that the pharmaceutical industry is an international industry. Yes, there are US-based pharmaceutical firms, but there are very important Japanese pharmaceutical companies that are international in scope. There are Western European pharmaceutical companies. So it really is not a US-centric development program. At the present time, most oncology drugs and most oncology applications only have about 20% of the patients come from the United States at this time. And many people would like to have more patients from the United States. One of the trends that we're seeing is less patients being enrolled in the United States, and that poses problems if one wants to have a diverse population because one is already starting with a smaller representation of the US population.
I see, thank you. Dr. Nakamura, your efforts to combine the Asian countries, I'm sure there's a lot of challenges because of the different languages and different cultural differences. And I'm sure there's a lot of different rules. Do you feel that they should have a global standard or global rules in clinical trials?
Yes. So I have noticed some gap, between the, Asian investigators' enthusiasm and the pharmaceutical companies' interests. So to close the gap, maybe so to obtain the good knowledge on clinical trials to join the global trial is important. So that's why we are giving a capacity building program for Asian countries. So there are two factors they don't have to conduct a good clinical trials in Asia. So the one is a lack of experience. So when I try to negotiate with pharmaceutical company to conduct Asian clinical trials, so some pharmaceutical companies are not very positive to conduct such Asian clinical trials because they are concerned about, they don't have enough experience like that. And the second thing is Asian clinical trial, Asian sites have some experience as a clinical trial sites, but they don't have a headquarter function. That means, headquarter means, developing a protocol or monitoring or statistical analysis. But those kind of factors, National Cancer Center can give such headquarter function. Then the National Cancer Center will, negotiate with pharmaceutical company. And, we can connect the pharmaceutical company with Asian clinical trial sites. That's what we are doing right now. And one thing I would like to add is, psychological trust is, one of the keywords of this today's session. And actually, I'm trying to involve the Asian countries, but the problem in Indonesia is the government, Indonesian government is very negative to send their tissue samples or blood samples to overseas countries. There is a reason. So previously, the pharmaceutical company actually conducted the clinical trials in Indonesia, and they collected the samples from Indonesian patients, but the intellectual property was owned by pharmaceutical companies. And fortunately, the drugs was approved by FDA, but Indonesia cannot afford the drug due to the high cost. So now the Indonesian government lose the trust on clinical trials. Then what I want to say is we have to always consider about a win-win situation between a developed country and Asian countries or some other countries. So to build up the psychological trust on clinical trials is one of the key factors of success in Asian clinical trials.
One of the factors that we would be remiss in not talking about is the emergence of mainland China into the clinical trial environment worldwide. And we have seen a rapid increase in the number of applications that are coming from mainland China, as well as participation in global clinical trials. And because of this, some of the diseases that have been historically understudied, such as hepatocellular carcinoma, gastric cancer, and nasopharyngeal cancer, are presently being studied because of the emergence of these companies that are located in China and are doing both China-only trials and also international trials. But I think we would have to be, as we talk about, the emergence and the contemporary worldwide development of oncology drugs, we have to really open a discussion on the issue of the emergence of clinical trial sites in mainland China, because that represents obviously a huge population of patients.
And I think, Rick, I have a question, because I think China is definitely a large population, but as Kenichi said, I think China also have issues. They have policy not allowing biological samples to be getting out from the mainland China, and that's also another challenge, isn't it? Or
I really can't comment on that.
Yeah. Mm-hmm. To be honest with you, I can't comment on that. I think I really love the points that Dr. Nakamura has raised. And those are very important points that he raised. He raised 2 points. One of the points that he raised was the idea that, it is very difficult to get pharma into majority of these countries, right? And although it is not difficult to get them to release their drugs in those countries, this is one of the challenges, that I think is very global when you're looking at countries, So if you're not invested in doing the clinical trials in those studies, but you are releasing those drugs in those countries and you are getting profit from those countries, and when you're being challenged to do the trials in those studies, you are saying, oh, you're not ready, or you don't have the infrastructure, or there's always a reason where you're not, and you're trying to engage it. I think this is for us to truly close the gap, and I really hope that CancerX can do this. I think there needs to be engagement of pharma and to put their feet to the fire, that you can't have it your way. You can't make profit out of these countries, then refuse to really have trials. The second point that I think Dr. Nakamura made, which I think is also important, is about that psychological trust. To be honest with you, we have seen a lot of some of those things that happen where your out samples are taken from countries, and the people in those countries are not benefiting, or the investigators in those countries are not benefiting. We call them vampire science. And I think there has to be ways to curtail those vampire science, to make sure that, number one, when that is being done, scientists from those countries are the ones that are leading the studies and are vested in the studies and are trained to be able to do those studies. And those are, it's very interesting to me that the points that Dr. Nakamura is raising are the same exactly points that we have in Africa as well, because I do a lot in Africa. They are the same exact point. And I think sometimes the South-South collaboration, maybe the Asia-African collaboration, can be a really strong way to come together and say, we are experiencing the same issues. Can we bind together and figure out how do we really do solutions that will be fair and equitable in all these countries?
I agree with you. I mean, I think the same issues is Pacific Islander, and we have difficult time even doing genomic testing because they're concerned the data is taken off from the island and you don't have any ownership and there's no IP, and they feel like they're getting, outside people are just taking it away, and it's very difficult conversation we're having with Native Hawaiian and Pacific Islander. Exactly what you just pointed out is happening.
And we should also not forget Central America also, and South America, but particularly Central America, because obviously in the United States, when we're talking about representation of underrepresented groups, we have a escalating and exponentially escalating population of a Hispanic population, primarily coming from the Central American triangles there, which represents a really unique population. And we really should consider that also, bringing insights from Central America.
I guess we should not forget that with this distrust, there is a history and a reason to these feelings that people have, and we should address that. And how about like community navigators who specializes in clinical trials? Is this something that like Dr. Ueno, places like in Hawaii, if in each island, if there's like navigators who can walk through the patients every step of the way, and if we can train these navigators, is there any possibility of that?
So that's something that we're also spending a lot of effort in it. And these are, whether you call it navigator or community leader. So we recently had basically a church leaders coming to the cancer center. And then we talk about clinical trials, and they have really no health care background, but church leaders of each of the community, or it doesn't have to be the Christianity, but some of their tribe leaders, it's extremely important. And even just to promote clinical trial related to like prostate cancer screening or HPV vaccine related approach, it has a significant impact. The elderly and the senior has an impact. So we spend a lot of time community outreach of education related to trials. And you're right that, of course, if we could get more trials from there, but we're still at a very primitive level of trying to provide basic information related for lifestyle modification and cancer prevention.
This is where we can collaborate, because we have done a lot in training citizen scientists, and we call them citizen scientists, and sometimes they're the navigators, but they're people that they are in the community, and then they are trained in specific area. In fact, one of the programs that we just have at Mayo Clinic is a curriculum that is built on clinical trials to be able to train lay people and train pharmacy technicians to be able to do clinical trials. So I would love to collaborate with you, because we need to be sharing these best practices that we are all doing. I definitely agree. Last Saturday I was in a church. We did a clinical trials education, and then from those clinical trials education, another thing that we're doing that might be a good thing that you want to look at is we are creating what is known as community cancer registry. And those community cancer registry are people they have been educated about clinical trials, and they say, yes, I want to know more, and I want to be matched to clinical trials at Mayo Clinic. We're creating a database so that we are very proactive. It is amazing how much our community wants to learn about clinical trials. If only we get out of our institution and go to them and train them. This is kind of one area that I feel we are very strong, that we are literally working with people in the community, whether they are faith-based organizations or they are non-profit organizations or they are just community leaders or cancer survivors. Is really very key. That's a very good point in using people who look like them and who can relate to them to navigate them to trials.
One of the things that we're doing at the FDA, we have a project called Project Community, okay, and it's an outreach program where we have provided information on clinical trials and go not only to the rural areas, but to the urban areas, but to rural areas, and including the inner city as well as other areas throughout the United States, but really recognizing also the role of families. And we have a week called Black Family Cancer Awareness Week, where we have really a concerted effort of really encouraging families to talk about cancer, because if one wants to build trust, usually that has to start really with the most trusted person anyone has, and that's members of their family. And I think that that's very important, that we really reach out and really try to strengthen also family relationships in discussing cancers, as well as as was previously stated, the very local community areas such as churches and other social groups that people participate in their own neighborhoods.
Thank you. Now, yes, go ahead.
Even in Japan, we have started some activities to involve the patients and the families, or the citizens to clinical trials. 5 years ago, there's no such activities, but JCOG and the National Cancer Center has started patient and public involvement since then. Then we have some, open seminars to talk about and work to talk about clinical trials, and we have some workshops. And recently, we have submitted the opinion paper to Japanese government together with National Cancer Center and the patient advocacy group. So that's kind of the collaboration with between the National Cancer Center and the community has started. And I think that's will facilitate the psychological trust on the clinical trials. So that's the Japan is now doing.
Wow. Okay, Dr. Ueno, do you have any final comments?
I don't have a final comment, but I just want to ask a question to everybody. Sorry to prolonging the talk, but how much do you think the pharmaceutical companies truly understanding the need for this area? I mean, there's a lot of push from FDA about addressing DEI. So I think a lot of pharmas now have a DEI division and really addressing it. But when I talk with them, sometimes it seems like they're not really grasping the whole entire situation. Or am I just, biased? Or
okay, we have 2 minutes, Dr. Pazdur.
Well, that's
30
a
seconds,
question, because I don't work in the pharmaceutical industry. I would say if they don't see it, they will feel the heat, so to speak. And I think that's what's important, that either you come willingly or you're going to being dragged into a situation, so to speak. So I think for the most part, they have really recognized this over the past year. This is a new area for them, and they have to think of how they're going to do this, okay? So it's hard to change a monolithic system, such as the pharmaceutical industry, in a year. So this is going to take time, but I think they do have a commitment, the people that we have talked to, and will work with us on these projects, because we are insisting on it, basically, that they address these issues. And the government has been, the FDA has been very explicit that this is a priority for them.
Okay, now this is such an important and very meaningful discussion, and we can keep on going and on, but unfortunately we are out of time. Thank you so much, speakers. This was great. This wraps our session of CancerX Global, and thank you so much for being here, and thank you so much for your time. CancerX Global X にお越しいただきましてありがとうございました。本当にまだまだディスカッションは続けていきたいところなんですけれども、時間がなくなりました。それでは、Thank you so much, everybody. Hope to continue this discussion in the future. Bye.
Thank you. Bye.
Bye. Thank you.
We remain on or leave?
I think
Please leave.
Yes.
Okay. Okay, Taro, see you. Bye.
Thank you.
Thank
Bye.
you, Dr. Pazdur.
Bye-bye.
Thank you, Dr. Nakamura. Thank you,
Thank you,
Dr.
Kaoriko.
Ueno.
Thank you, Kaoriko, Kenichi. Bye.